Good morning. Today we're going to be discussing one of the most important topics in pediatrics, which is the diagnosis and management of dengue. So our objectives include accurately diagnose dengue fever in children given clinical signs and symptoms, and appropriately manage a child presenting with dengue fever. So dengue is a mosquito-borne viral disease. It is transmitted by a female mosquito, mainly of the species Aedes aegypti, and to a lesser extent Aedes albopictus. It is widespread throughout the tropics, with local variations in risk influenced by rainfall, temperature, relative humidity, and unplanned rapid urbanization. The etiologic agent of dengue fever is a virus belonging to the Flaviviridae family, with serotypes DENV1, 2, 3, and 4. Recovery from infection is believed to provide lifelong immunity against that serotype. Cross-immunity to the other serotypes after the recovery is only partial and temporary, and subsequent infections by other serotypes increase the risk of developing severe dengue. Signs and symptoms include a severe flu-like illness that affects infants, young children, and adults, but seldom causes death. It usually lasts for 2 to 7 days, and the incubation period of 4 to 10 days after the bite of an infected mosquito. The disease has three phases: the febrile phase, critical phase, and recovery phase. The febrile phase is heralded by the start of fever from 0 to 7 days of the disease. The fever is said to be biphasic in pattern, and we should monitor the effervescence and warning signs to recognize start of the critical phase. Signs and symptoms of the febrile phase include a very severe headache, retroorbital eye pain, muscle, joint, and bone pain, presence of a macular or macular-papular rash, and minor hemorrhagic manifestations, which include petechiae, ecchymosis, purpura, epistaxis, bleeding gums, hematuria, or a positive cervical test. Some patients have injected oropharynx and facial erythema in the first 24 to 48 hours after onset. Warning signs occur in the late febrile phase around the time of effervescence, and this includes persistent vomiting, severe abdominal pain, fluid accumulation, most commonly seen in the abdomen, mucosal bleeding, difficulty breathing, lethargy or restlessness, postural hypotension, liver enlargement, and progressive increase in hematocrit. Laboratory findings in the febrile phase include CBC with decrease in WBC, mild to moderate thrombocytopenia, an elevation of your AST and ALT, and hyponatremia. So the next phase is the critical phase, and it begins at the effervescence and typically lasts for 24 to 48 hours. Most patients in the critical phase clinically improve, But those with substantial plasma leakage can, within a few hours, develop severe dengue as a result of a marked increase in vascular permeability. Initially, physiologic compensatory mechanisms maintain adequate circulation, which narrow pulse pressure as a diastolic pressure increases. Clinical manifestations in the critical phase include the following: severe plasma leakage, seen as pleural effusion, ascites, hyperproteinemia or hemoconcentration; hypotension, when systolic blood pressure rapidly declines and irreversible shock and death may ensue despite resuscitation; severe hemorrhagic manifestations, which includes hematemesis, bloody stool, or menorrhagia, especially if they have been in prolonged shock. Uncommon manifestations include hepatitis, myocarditis, pancreatitis, and encephalitis. The following laboratory findings can be seen in the critical phase: an increase in hematocrit, moderate to severe thrombocytopenia, leukopenia, and a transient increase in ATPC to decrease in fibrinogen. After 48 hours from the critical phase, the recovery phase follows, wherein there is a gradual resorption of extravascular compartment fluid in 48 to 72 hours. As plasma leakage subsides, the patient enters the convalescent phase and begins to reabsorb extravasated and intravenous fluids and pleural and abdominal effusion. The hemodynamic status stabilizes and diuresis ensues. Hematocrit stabilizes or may fall because of the dilutional effect of the reabsorbed fluid. The white cell count usually starts to rise, followed by a recovery of platelet count, and the convalescent phase rash may desquamate and be pruritic. In the recovery phase, the white blood cell count starts to rise. Hematocrit stabilizes or slightly lowers due to dilution effect of the absorbed plasma, and platelet count increases with white blood cell recovery. In the year 2012, the Department of Health and Philippine Pediatric Society formulated a revised dengue clinical case management guideline, wherein the dengue will be divided into three classifications: dengue without warning signs, dengue with warning signs, and severe dengue. Patient is said to have probable or dengue without warning signs if the patient lives in or travels to a dengue endemic area, plus fever and two of the following clinical features: headache, anorexia, myalgia, flushed skin, arthralgia, rash, retroorbital pain, Uptourniquet test positive, nausea and vomiting, and lab test at least CBC demonstrating leukopenia with or without thrombocytopenia, and or a dengue NS1 antigen test or dengue IgM positive test. With dengue is classified with warning signs if the patient lives or travels to a dengue endemic area with fever lasting for 2 to 7 days plus any of the following: abdominal pain or tenderness, lethargy or restlessness, mucosal bleeding, liver enlargement, clinical signs of fluid accumulation, decreased or no urine output within 6 hours, persistent vomiting, and laboratory increase in hematocrit and or decreasing platelet count. Additional tests to confirm a dengue fever include viral culture isolation and polymerase chain reaction tests. For severe dengue includes living in or travel to a dengue endemic area with fever of 2 to 7 days and any of the above clinical manifestations for dengue with or without warning signs plus any of the following: severe plasma leakage leading to shock and fluid accumulation with respiratory distress, severe organ impairment wherein an elevated AST or ALT pertaining to a liver impairment, seizures and impaired consciousness, myocarditis and renal failure, and severe bleeding.